Hello, good Friday to you all. I missed the countdown, so I wasn't sure if we were live or not. Normally I get this 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and now we're live. But it looks like we're live. And so on this Friday before Christmas and our last SADS Live of 2024, great to get to be with you. I'm Mike Ackerman, genetic cardiologist at the Mayo Clinic here in Rochester, Minnesota, where we have snow, and director of Mayo Clinic's Genetic Heart Rhythm Clinic and the Winland Smith Rice Sudden Death Genomics Laboratory. But I'm here today, as in all of the previous SADS Lives, on behalf of Alice Laura, our CEO, and her team for the Sudden Arrhythmia Death Syndromes Foundation, the SADS Foundation. You can find us on the website, www.sads.org. If you prefer how we like to think about it, www.stopsads.org. And that's not to stop the organization, that is to stop the tragedies from these genetic heart conditions, to stop the nonsense related to some of the issues surrounding our families in terms of how the warning signs are not recognized. And sometimes there's a profound delay in diagnosis. So can we stop that? So stop the overtreatment. Way too many defibrillators thrown in way too many patients who don't need them. So stopsads.org. And we hope for you, whether you have a SADS condition or you have a loved one with one, that you find the SADS Foundation as a place of confident and competent information, guidance, support. Alice and her team are really, really incredible, and we're here for you. And today's final SADS Live of 2024 is devoted to your questions, which are always amazing and stimulating, and my answers, which I don't know if they're amazing or stimulating, but I do my best. And before we look at the questions, which I'll keep an eye on as they come on in, speaking of wrapping up 2024, make a difference, won't you? Be part of the life-saving and life-giving mission of the SADS Foundation and give to SADS. You go to that website, www.sads.org, top right corner, donate now, easy to do. I did it just 3 days ago for a year-end gift. Won't you join me in a year-end gift of some of your time and some of your treasure for the SADS Foundation? It makes a huge difference. So will you join me in being part of year-end giving to the SADS Foundation? Next month, we'll be kicking off the new year, and we'll be kicking off with the SADS Foundation some exciting things with Health and Wellness Month. And so can't wait for the new year. Although I love to linger on this year. I loved 2024. Special things have happened. I almost was late today, believe it or not, to this. I ran over. I had an incredible collection of patients and families this morning, and I didn't think we would finish in time, but things turned out to work out just right. Well, with that, I am going to start. Remember the drill. I look over to the right, or maybe your left as you see it on the screen. I see what question is posed, and I try to make my best answer. I take them in order, so no cherry picking. I don't do that. And we'll see how we do together. Let's go. And 27, right? No, we have 37 minutes on the counter. And the first one of today and the last session of 2024 is from Jackie. And Jackie is saying that a 7.5-year-old son was hospitalized in August. They had given him heavy doses of albuterol. That's the pump inhaler for asthma. And after PVCs and bigeminy on the monitor, they did an ECG, which showed a long QT interval, and it was still long the next day. The pediatric EP at CHOP later hand calculated it down to different numbers, 447, 458. And they've always been low. His stress test, that's EST, exercise stress test, showed a 447 at 7 minutes of recovery. And then it continues. And it broke off, so I'm not sure what the question is. Jackie, it was a great one. I suspect we're wondering, does your son have long QT syndrome or not? Now, I can't speak directly to Jackie and her 7.5-year-old son. What I can say is in setups like these, where there's the question of the veracity of the diagnosis, was the medication to blame? Is there an underlying vulnerability? That patient and that family deserves a very, very careful evaluation to decide about the veracity of the diagnosis of long QT syndrome. You are in good hands. I bet I know who your son and you might have seen there. Great people at CHOP. And so I'm sure this will resolve well. And Kim is wondering if whether you can see the Brugada pattern on the CardiaCare 6-lead ECG. Now so she's wondering about how well does the CardioMobile 6L device, can that potentially show the Brugada pattern? The short answer is maybe. I'm not sure. We've never really looked at the reproducibility or accuracy of the 6L leads, the 6 leads. Now, eventually, that company and others are working on smartphone-enabled mobile ECGs, all 12 leads. Now, if and when the all 12 lead gadget is released, then for sure we will be able to detect the type 1 Brugada pattern. And greetings to you, and diagnosed with, new diagnosis of long QT just this week after a routine ECG followed by the Holter. What is the significance of the mean and maximum QTC on the Holter? And in your case, it said it was 512 for the average, the mean, and 731 for the maximum. I love the question, Anne, and I'm sorry that you have to join the SADS family, but you will absolutely live and thrive. Now that, of course, depends, is the diagnosis correct? Meaning, do you belong in the SADS family? Do you really have long QT syndrome? I'm going to assume you do, and that person is being cared for correctly. The specific question is about the Holter, and in that 24-hour Holter or 48-hour, some of the Holter companies report out the QTC profile, the minimum one, the minimum QTC value recorded during that time, the average or the mean, the maximum, the highest. And sometimes they'll also say, what was the percent of time that the QTC was greater than 450? Not exactly sure why 450 had to be chosen, but that's what they do. Now, full confession, I actually don't use those numbers from the Holter at all. Zero. The reason I don't is because I'm not confident in the accuracy of the measurement. There's almost no way, for example, that you or anybody who's an adult has a true QTC of 731 unless at the time of that maximum value, they just had taken by IV one of the most potent QT prolonging drugs we might have. So I don't think that maximum is probably anywhere close to truth. I'm also just not confident in the measurements from the Holter. And so what's important is we have risk stratifying information based upon the 12-lead ECG and that average QTC on that morning 12-lead ECG. And for most of our programs, it's always the morning data point, for which over the last decades, we can kind of provide some forecast, low, medium, high, spooky risk based upon that ECG. You would think if we had chronic data, 24-hour data of information, that we could be better risk forecasters, and maybe we will eventually. I just don't think we're there yet. I don't turn that feature on. So I'm not concerned at all about those numbers because honestly, we don't have any good data to tell us what those numbers mean when it's in that context. Kim's asking of whether we can take Ozempic with Brugada pattern 1. Now, Ozempic is one of those weight loss medications for diabetes and so forth. It's the general class of medications are these GLP-1 agonists. And those drugs, the good news is there's no signal of interference or aggression or accentuation of people with genetic heart diseases. So, to my knowledge, there's no QT agitating, prolonging signal. There's no agitation to the Brugada substrate, and there's no reason to think that it would be irritable to somebody with a genetic heart disease, heart muscle disease like ARVC or ACM. So, I wouldn't worry about using medicines like that for my families with a SADS condition. Ann's wondering whether, oh, good questions today. Oh my. Better stay on task and not linger too long on anyone. With 30 minutes on our counter, does altitude have any impact on the QT? I often have to travel to, oh, wow, that's cool. So you travel. So no, I'm not worried about altitude for the QT interval. I've never convinced myself that altitude had anything to do with timing of an episode, triggering an episode. And I don't think there's any good evidence that the distribution of QT intervals in health and disease is different between sea level and higher altitude. On average, from Ricardo, wondering with CPVT patients, does treatment with Nadolol cause fatigue? And I think we can extend that to do our preferred beta blockers that I love for long QT, love for CPVT, do those preferred beta blockers. And as many of you know, I and other long QT, CPVT experts throughout the world strongly prefer Nadolol or propranolol. I like both of them a lot. So, for example, I kind of like propranolol better for somebody who has LQT3. All things considered, I like Nadolol the best for long QT1 and CPVT. Now, no matter what your disease is, whether you and a beta blocker will agree with each other, that depends on a lot of factors. And so I probably have a skewed bias of the beta blocker side effect of fatigue because my patients gave me, taught me, told me about the beta blocker zombie. I did not invent that term. My patients gave that term to me. But that term captures that side effect for that population. And because we at Mayo Clinic have advanced innovative therapies that potentially enable somebody to have a beta blocker free treatment solution or a lower dose beta blocker solution, there's been a migration of patients who have said, count me in, I hate beta blocker. And when you do that, you start to think that the beta blocker causes fatigue in everybody. The truth is it doesn't. In many, many patients, they find the beta blocker and the quality of life equation completely acceptable, completely satisfying. In fact, I have some patients who like themselves better on beta blocker. I have some athletes who like their performance better on beta blocker. So it's not a one size fits all. I generally view it as if I think your disease has to be treated, and I think we will start with the beta blocker. If we get to a dose that I like and feel like I have you treated well and you tell me we're good, then we're good. If you tell me, sorry, we just took a disease that has never reared its head in me for 30 years, and now you gave me a new disease, doctor, called everyday beta blocker fatigue, then that's not good enough. We have to start over. We have to rewind and reconfigure a different treatment program because we have options. In the past, we had no options. In the future, we're going to have even more options. That's going to be an exciting future. So it's hard to say, does it cause fatigue? In some, it does tremendously. In others, not at all. Charlotte from Instagram Would identified gene with no presentation of disease ever be a cause for lifestyle modification? Example, PKP2. Great question. So, in general, that label of I own the genetic marker, but I don't show any measurable clinical features that would enable somebody like me to make the diagnosis of that condition if I didn't know you own the genetic marker. That description is something that we call genotype positive. I own the genetic marker, but phenotype negative. I don't show the measurable evidence that the disease is there in my heart. And so we're wondering, do we need to do lifestyle modification when we're in that category? And the answer is it depends. So, for example, if you own a long QT genetic marker, but your ECG is normal, would I still want us to be careful about being exposed to drugs that are on the QT hit list? Great list, www.credible.meds.org. And the answer is yes, I might want to know that, because one way that could potentially convert your disease from non-existent to wow and potentially tragic is that combination, that 1-2 punch. So for them, I would tell them about a preventative measure. Now, for yours specifically, when you mentioned the gene PKP2, that's interesting. That gene builds a protein called plakophilin 2, and patients with PKP2 mediated genetic heart disease, that's the most common genetic subtype of genetic ARVC, arrhythmogenic right ventricular cardiomyopathy. And we know there's outstanding data that has emerged largely from the Johns Hopkins team under the direction of one of their genetic counselors and PhD geneticist, Dr. Cindy James, where it certainly looks like in both mice and in humans that exercise, specific kind of exercise called high intensity endurance training, may in fact, and looks to be, disease accelerating, disease agitating. So I don't like, and I encourage my PKP2 athletes not to be marathoners, triathlons, long distance swimmers, rowers. But the question of, if we find somebody in that phenotype negative state who owns that PKP2 genetic marker, does that mean that we need to shut all of them down from all exercise or even high intensity exercise, or only? And there, I'm not sure we really know the final answer, because one of the things we wrestle with is that disease, PKP2, is not 100% penetrant. In some of the owners of that marker, it will never, ever, ever show itself, even if you are a marathoner. And it's called incomplete penetrance. And our challenge that we have is we don't really know who is non-penetrant, meaning, yes, I own it, but it will never show itself no matter what I do in terms of my lifestyle. So as a general rule, for my PKP2 positive patients who don't show the disease, I let them do almost everything they want. We keep a close eye on things. If the disease starts to rear its head, we throttle back on the activities they were doing. If the passion isn't a marathon, then I don't ask them to do one. So maybe we steer them or guide them to say, well, pick up sports, but let's maybe not choose those. In fact, I love the question so much that in January, our first program of the new year, January 10, I believe, January 10, 2025, I'm looking on my calendar just to confirm, yes, is devoted to sports, genetic heart disease, the intersection. What can I do? How are we doing it now that we are moving slowly from 3 decades of if in doubt, kick you out, can't, don't, to how do we do this? And how do we stay an athlete safely? How do you become an athlete with a genetic heart disease and end up as a national champion and now in the NBA, or end up as a professional hockey player? You see that there, or a dance champion. And so we're going to have a program devoted to that. And we'll just say it's inspired by your question, although we had it scheduled um, about an hour ago. Let's see. From Kayla. Hi, Kayla. What age do I recommend telling a child with a condition that they have one? How do you recommend having that conversation without getting into the weeds or generating anxiety? Oh, I love that question, Kayla. I think every child's different. Having four children of my own and having all four of them be as different from each other as can be, there's not a one size fits all solution. I think it's tailored to them. Just like the family I saw today, I would told the mom and dad, you know what? Your 5-year-old is listening very carefully. And that's why I'm saying during the evaluation, you have a very strong, very healthy heart. So does your mommy, so does your daddy. Because I don't want to say words that plant seeds that make people acquired cripples, where they fear that they are fragile and they embrace a fragile perspective rather than I've got this and I'm going to thrive with it, rather than I've got this and it's going to get me. And so as a parent, I think we all always choose, what do we reveal when? So do I need that 5-year-old to know what her long QT substrate is about? No. Will she need to know about it at age 10, 11, 12? Maybe. Time will tell. But in general, I'm always honest, but I use that honesty with given the expectation that we will always win with that heart condition, that I want them to feel that hopeful and hope filled and not fragile. And sometimes we as parents, we inadvertently make our kids embrace fragility as they are delicate in that way. So I try not to do that. And so I don't know if I answered that fully, Kayla, but it is when the time is right, I start to speak to the child and have them own the disease. So we work on a transition to where it's now a mom and dad's issue to navigate their child's wellness and have their child living and breathing, that they're strong, normal, fast. And then when it becomes time, we start to gradually ask the child, what is the name of your medicine? What's the dose? When do you take it? So that we transfer ownership of that journey to the child at the right time. Do I recommend genetic testing for borderline QTC in children? Was originally told no, but after asking too many questions, being told to do it. It depends. So I love the question, but I need to think that we're dealing with long QT syndrome. So if all I'm being told is that there's a borderline QT interval, and that's the only words being attached to it, and there's nothing else, I don't do genetic testing. I try very hard not to use that term borderline. I don't like the term. I think what happens all too often is we in medicine will say you have a borderline QT interval, which means you might have possible long QT syndrome. And although that's a true statement, that may only be a true statement less than 1% of the time. So I'm not sure that's a helpful statement. So all things considered, I need something more than a one-time ECG that reported a QTC of 449.7 or 453.6 that made somebody use the word borderline in front of the QT interval. I need more than that before I'm going to pursue a long QT evaluation. So Anne's giving me some follow-up, so thanks for that follow-up. And then, I like that name. I hope I pronounced it right. Amaya is asking how my day is. My day is great. Thank you for asking. And she's wondering if there's any new therapies for ARVC, specifically in regards to them being able to one day perhaps participate in sports. It's sad that among all the SADS conditions, this is one of the few that 100% disqualifies you from sports. Wow, a lot to unpack there. Come back for January 10, Amaya, because that statement that you say may be true in some programs, but is absolutely categorically false in my program. I do not and have not for 20 years 100% disqualified people from sports just because they have ARVC. We talked about a little bit earlier with PKP2. Might we redesign their sports life and what they do, what's their density of training, how they train? But do I kick you out just because you are tagged with ARVC? I do not, and I have not for 20 years. And we are starting to examine that. In fact, as some of you know, we have an NIH funded grant that was called Live Long QT Syndrome, the corresponding one called Live HCM. And Rachel Lampert, Charlene Day, and I are creating the third one, part 3, Live ARVC or Live ACM, where we're actually going to look and try to really understand how concerning, dangerous is sports participation, and what's the balance between that lifestyle versus a sedentary lifestyle and quality of life. So we're working on that. Stay tuned. But as to new therapies, I think there's been a couple of exciting new therapies that we use right now. So there's some great work that came out, led in part by a good friend of mine, Wojciech Zaryba at the other Rochester, New York, where based upon work from a really awesome scientist and friend, Dr. Mario Delmar at NYU, where we've seen that because PKP2 ARVC at a molecular cellular level kind of mimics the calcium mishandling of a different SADS condition called CPVT, where we know that drugs like Nadolol and flecainide work great. We're starting to use those medications for patients with ARVC. In fact, in our program at Mayo Clinic, Dr. Judah Sessi and I will do stress testing, and we will, if the stress test for that ARVC patient shows exercise associated ectopy like it does in CPVT, we will start them on these medications, and we will work towards the goal of up titrating the medications to get that stress test to look like mine, normal. And so that's a new strategy. In fact, that's probably maybe a 1 to 2 year old strategy. There's other new therapies. Amaya, for example, there are 3 different companies, Rocket Pharmaceutical, Lexeo, and Tenaya Therapeutics, that have all launched clinical gene therapy trials in patients with PKP2 mediated disease. So patients are being enrolled in all of those studies. And so gene therapy as a possible solution or treatment for ARVC, specifically PKP2, is starting. We're going to learn about safety. We'll learn about efficacy in the future, safety signal first. So those therapies are underway. So lots is happening. Kim's asking whether a PVC has anything to do with Brugada pattern. And had a loop. Your son has a loop recorder. I've been having a few PVCs a week. No. So in general, we have a Brugada pattern if we have Brugada syndrome, and it shows itself on the ECG. And some of us, many of us, have background PVCs, skip beats, extra beats. PVCs stand for premature ventricular contractions. The bottom chamber, the ventricle, is beating when it's not supposed to. And that's a PVC, or a premature beat, an extra beat, skip beat. Now, all of us have them. There are normal patients who could have 1,000 a day, 5,000 a day, and they don't feel a single one of them. There are other patients who have 1 PVC a day, and they can tell you exactly when that one occurred. Now, by itself, PVCs isn't part of the Brugada story. It is possible that if a person has a normal PVC, that PVC could intersect with, agitate, tick off, trigger the Brugada rhythm or the long QT rhythm or the CPVT rhythm issue. But in general, a few PVCs here and there is of zero concern. Christy from Instagram, your sons with LQT type 2 have ADHD, attention deficit hyperactivity disorder. We've tried multiple meds that haven't helped the teenager, the 13-year-old. We're so hesitant to do a trial of stimulant because it's on the no list. Can you speak into this? I would love to, Christy. Not again for your son. I don't know his story. I don't know his QT number. I don't know whether I would call him no risk, low risk, medium risk, spooky risk. I'll just share with you in general what we have said and what we have published. So in our program at the Mayo Clinic and the SADS Foundation in general, we respect that those stimulants, therapies for ADHD, ADD are on the hit list of the drugs, the no list, like you said, on the crediblemeds.org list, which you can find on the SADS website. You can go direct to that Credible Meds. You can download an app from Credible Meds. I love that list. Full disclosure, I'm a scientific advisor for Credible Meds. Now, I respectfully disagree with their inclusion on the list. Their inclusion on the list is because these stimulants are stimulants. And since they look like chemistry of adrenaline, and since we say that LQT1 is triggered by adrenaline, that CPVT is triggered by adrenaline, that therefore anything that has stimulant-like activity, adrenaline-like activity, needs to go on the list and needs to be avoided. It kind of makes sense, doesn't it, as a precautionary measure? But I think everything in life is about risk benefit, is about getting it dialed in just right, not too hot, not too cold, just right. Remember Goldilocks and the three bears? And I think this is the same. So I have lots of patients with long QT syndrome, CPVT, and concomitant ADHD, ADD. Lots. So you can imagine how many lots are. I take care of about 2,000 patients. And the frequency prevalence of ADD, ADHD in my long QT patients is basically exactly the same as the general population, 7%. So 10% of 2,000 is 200, 7% is 140. That's a lot with both conditions. And to leave a patient who has long QT and concomitant ADHD, where the two do not have anything to do with each other, they just coexist, 7% of them do, untreat their ADHD doesn't make any sense to me, to leave them miserable. Now, are we over treating ADD, ADHD people with drugs or too quickly treating? Whole nother discussion. Not that's sort of stay in your lane, Mike. That's not my lane. But in my patients where they do have ADHD and their ADHD specialist says they do have ADHD and the non-prescription cognitive behavioral therapies, other strategies aren't working and the child or adult is not thriving, we have to treat them. And we know that we can take them on therapy and increase their quality of life dramatically. I have formerly untreated patients who were F students, D students, doing awful, now thriving. And so I just don't agree with the idea that we will consciously, intentionally not treat your ADD, ADHD because those drugs reside on the no list. So we haven't done that. We don't do that. We've published and have shown in our cohort of patients, if we look at those patients who had their ADHD, ADD treated intentionally with stimulants, if chosen, that the event rate on their long QT syndrome is no different than those who had their ADHD left untreated. No difference. What was different is the quality of life of those who had their ADD, ADHD meaningfully treated. So we treat all of the patient head to toe. Just dealt with a very challenging patient with long QT syndrome, which I think is overall low risk, but needs mental health therapies for very debilitating anxiety and depression. And we're not treating that very well because everybody is like, can't, don't. It might do something to the QT. And so we're leaving the person in a miserable state because of our unwillingness to tackle treating the whole patient. So I'm not worried about just the heart. I wonder and I care for the whole patient head to toe. So that's how we do it. Is long QT associated with migraines and auras? No, it's kind of like ADHD. So not really. Now I should have mentioned with ADD, unlike long QT, where I don't think there's any difference in the rate, in CPVT, there's probably a higher rate of ADD, ADHD, and learning disabilities than that in the general population, meaning the CPVT mutation in the heart, that abnormal ryanodine receptor is also present in the brain, and that may set up the potential early on in life, in utero, in infancy and toddler, for the possibility of cognitive learning disabilities and things like that. But that's not true for long QT, and that's not true for migraine. So I've never been impressed that the frequency of migraines is any higher in my genetic heart disease patients, no matter what their heart condition was named, compared to the general population. Like ADD at 7%, migraines has a background frequency in the general population, and that background frequency is basically the same as in my long QT patients. We have approached the top of the hour, and my next one in the queue is a long one, or a long stem. Let's see if I can do it. I can do it. And then we will pick up with your questions the next time, but the next time might not be until February question and answer session, as January 10th is going to be sports, athletes, wellness, health. Don't miss that. But here we go. From George, 74-year-old man with Brugada. 2 years ago, got an ICD after spells. Told that your Brugada is caused by long-term use of imipramine for anxiety and depression, which you had been taking for 35 plus years. I made several attempts to switch to a different antidepressant without success. No family history, DNA negative. How common is it for Brugada to be caused by that drug or by drugs? That's such a good question to finish up on, George, with 3 minutes on my counter. So first off, if a person truly has Brugada syndrome, their ECG is diagnostic of the type 1 Brugada pattern. Only about 20% of those people correctly labeled with Brugada syndrome will have a positive genetic test. Now, it could be as high as 40% if you show the Brugada pattern and you have something called PR, P. Paul, R. Richard prolongation. Then the genetic test is about 40%. Either way, that means that most people who are correctly called Brugada syndrome do not have a monogenetic driver, one genetic hit, the smoking gun. Most are gene test negative. Now, we learned that some of that most have what's called oligogenetic architecture for their Brugada, meaning they have a collection of common things such that that collection conspires to give them what looks like the equivalent of a single smoking gun, a single sodium channel mutation, for example. Then so some patients, 20 to 40%, have smoking gun Brugada syndrome, single genetic mutation. Some of that remaining 60 to 80% have the perfect storm of genetic markers. And the rest, have non-genetic Brugada. Now, some of that non-genetic Brugada are a lot of things that can bring out the Brugada pattern called not genetic. So, for example, cocaine will give a Brugada pattern. Marijuana will give a Brugada pattern potentially. And drugs on the Brugada hit list www.brugadadrugs.org can not only give you the Brugada pattern, but in somebody with a genetic Brugada syndrome, they could be Brugada aggravating. So in your case, you mentioned one specific antidepressant drug, imipramine, and that drug is on the Brugada list. Is that the only reason for your Brugada pattern? Maybe, maybe not. Would I be avoiding it in a person who owns an ICD? Honestly, in my patients, not you, George, but if I have a patient who the decision has been made to treat with an ICD, I fear that Brugada list or that QT list not very much at all, especially if we're losing in treating all of you. So if we're losing in the mental health battle and that drug that was winning and giving us victory was called imipramine and it's on that list, I don't worry about that anymore because I've got the antidote installed. Do we monitor you carefully, a person like that? Yes. Do we adjust some things? Yes. But do I view that list of the no-no list as absolutely off limits once we're in that scenario? In my program, I don't do that. And with that, on that, I don't do that. I will give you what I do, and that is I do want to wish all of you a very Merry Christmas. For those of you who celebrate December 25 as the birth of our Lord and Savior Jesus Christ, it is not a holiday, it is a holy day. And for those who do celebrate that holy day of Christmas, I wish you a Merry, Merry Christmas. For those who don't, I wish you a happy holiday. And as we bring this year to a close, and for all of us, I wish you a happy new year. And I can't wait to see you again next year in 2025. Blessings, everyone.